that would be great. Welcome everybody to our wonderful women's wellness talk tonight with Dr. Wendy Day, primary care doctor. Just a couple of special reminders. Thank you for being here as it's the last presentation we've had in our second group of women's health. We've covered pelvic floor, we've covered nutrition, we've covered heart health, we've covered sleep and stress. We've covered things such as women's health for ablations and hysterectomies. And tonight we're going to be covering a little more deeply into hormones, the fun of menopause, hormone replacement therapy, and any open questions you have for Dr. Day. She's primary care. She knows everything about pretty much everything.
Oh, I wish. Thank you. No.
So she has been my primary care doctor for, I believe, 25 years. Yeah, 25 years. That's a long time. Very hard to get into, as everybody wants to get into Dr. Day, because she always makes it a good day. Okay.
Thank you.
Even though all week it's been a really windy
day.
So,
well done, Christine. Well done. Well done.
But what I love about Dr. Day, she has so much experience in internal medicine for over 20 plus years. Used to also be at Penrose Hospital. So those of us that were there could hear her name over the announcement quite a few times. She has so many things that she expertise in. But what I love about what she wrote on her UC Health kind of introduction is that her greatest strength as a physician is in communication skills. I love how she didn't write all these things about all the stuff she knows, but rather that she communicates well with people. So I went to a doctor before her that I came in the room and the doctor asked me, have you ever had an asthma and heart attack and blah, blah, blah. And I was like, the doctor didn't even look at me in the eyes. She didn't even care who I was. It was just like a list. And then I went to Dr. Day and I was like, I'm in love. This is great. She actually cares.
Oh, you're so cute.
And she's Patrick's doctor as well. And she always kind of sits on the ledge and talks to you about your family and really gets to know you and really understands more of the stresses and things that we go through in our life. The other thing that's great about Dr. Day is she loves to be physically active. She's from Pennsylvania, but she's lived in Colorado for 19 years. She has 3 grown girls, twins in college, and also a daughter at the Air Force Academy who's flying and doing all this cool stuff. So they all like to challenge themselves with races and jumping out of planes and everything else. Dr. Day loves to ski, bike. She did a huge mountain bike race, which she'll tell you about once I finish this. Hiking, running, new passion for off-road dual sports motorcycling. Loves watching action sports, anything that's moving, football, basketball, and she's a diehard Packers fan, and has volunteered in our SET clinic, which is a really nice clinic that we do for uninsured patients here in town, and also volunteered as a camp physician for 4 years running her daughter's sailing camp in North Carolina. So too bad Jennifer is not on today. She just got certified as an official sailor.
Yes.
So
nice.
She's my college roommate, and now she sails, which is pretty awesome.
Oh, I love it.
So without any further ado, I want to thank everybody for being here tonight and being ready for her talk. She's going to talk about 15-20 minutes about this topics, and then in the chat along the way, if you guys have questions and if you have menopause brain and you can't, you're going to forget it like within 5 seconds or something, go in the chat and write in your questions right away so that we don't forget what they are. And that way, if they relate as we go, we can, let her know there's a question, or we can wait till the end, depending on the topic. So without any further ado, thank you so much, Wendy Day, for being here tonight.
Absolutely. Absolutely, Christine. Thank you. Thank you for the awesome introduction. I feel like I'm a rock star. So, and that's very important, that I feel really like I'm awesome. But I guess the probably the biggest thing that I want to confer to y'all is that I'm a normal menopausal woman. I'm 55 years old. I have been I don't even know, probably 3 years or so into the fun menopause. So I'm living this world. I know exactly what it looks like. I know exactly what it feels like. So when I'm talking my women through this, hello, I know exactly what it is, and I know how to battle it, and or how to move with it, I guess is the right answer. Here's the thing about menopause is that essentially what's happening, what you'd figure is that we've got we got ovaries, they have a certain number of eggs. As life goes on, each time we ovulate, we're throwing that egg out, throwing that egg out. We have a finite number of eggs. So what happens as we hit our 40s usually is that our body's like, yep, we're getting to the tail end of those eggs. I don't have many more. And so your hormones go, what the heck? I don't need to regularly fluctuate anymore. So, and what you'll start to see is that usually somewhere around 40-ish, that the hormones are ratcheting down. You start with these beautiful reproductive hormones, and then as you hit your 40s, they're starting to ratchet down. They're starting to ratchet down. The eggs are going, okay, I'm done, no more partying. And then by the time you reach, and it's typically 50 for most women, but it could be plus or minus, then your uterus is like, you don't need me anymore. So essentially, what happens for most women start to feel some perimenopausal. We call them perimenopause. Perimenopause is like, I'm not officially menopausal, but I'm having some of the symptoms. So the most common early symptoms that women hear, well, night sweats and hot flashes, they start early for some women. Insomnia, yes, welcome to the land of hormones. And it's not always a night flash related insomnia. It's just like, oh my goodness, I can't sleep. Why? So that can happen young. The weight gain, the weight gain that happens with the menopause, it's like literally you blink and overnight you've gained 10 pounds. And you like, but I didn't do anything different, doctor. Yes, because this is menopause. So, so that process is all starting as early as 39 is the youngest, but most women somewhere in their 40s start to have these changes. And then the average age of when you actually stop having periods for most women is going to be around 50. But what happens for a lot of women is they'll start skipping periods. They either have irregularity to their periods, they'll have it a little bit more frequently, a little bit less frequently. And then as time goes on, the time in between periods stretches. And then, and what happens for most women is they'll have like 2 or 3 periods in a year, and then eventually it'll be 6 months without a period. And then finally, it'll be a year without a period. And that happens, when that happens, that's menopause. So welcome, you're in menopause. So now you've had a hysterectomy. Okay, let's say you have ovaries, but you've had a hysterectomy. How do you know if you're menopausal? Well, number one, you'll start to have the same symptoms, but it won't happen necessarily right where you had the hysterectomy. And that's when you talk about, okay, when to check hormone levels, that's when you can check hormone levels. And we'll talk about what those look like. But the thing is with that is that hot flashes can be a lot of different things. I mean, so you can have an overactive thyroid and have it be what you perceive as hot flashes. So you can be sick, you can have other conditions. So there are a lot of different things that can mimic those symptoms. So that's where the hormone levels come into it. You're in that menopause frame. What are your symptoms? Well, most common symptoms are hot flashes, and anybody who's had one knows what they feel like. They're miserable. It's like a furnace just takes off inside of you, and you can't get naked enough is what happens. And they can last usually for a minute or so, and they can be really disruptive. Night sweats, yes, you wake up and you take off all your sheets and you take off all your clothes, and your husband's not really enjoying that at the time. And then you're freezing, and then you're up. And it interrupts your sleep. So you're constantly waking yourself up with night sweats. Maybe they drench you, maybe you have to change clothes, things like that. Mood. Many women have mood fluctuations with menopause, and but it's challenging because there's usually a lot of moving parts in these ages. We have kids that are growing up, we have kids that are having challenges, we have parents that are aging, we have parents that are dying, we have friends that are sick. So these are stressful times. So there's a part of that comes in as well. Brain fog, yeah, a lot of women have that sense that, oh, gosh, I just can't concentrate anymore, I just can't think clearly. That's a very common thing. Vaginal dryness, that's a big one. Sexual dysfunction, those are big ones. And those are things that interrupt relationships. And what happens with a lot of women is that, especially as they go longer, they're like, well, it hurts to have sex, so why do I want to? And then you have a hubby that's like, what do you mean you don't want to have sex? And so there are relationship issues that come along with that. Um, and the other things that happen with menopause, the medical things that we know definitively happen, is that our heart disease risk goes up after menopause. And that's been shown in different literature. Before menopause, we're lower, and then after menopause, we hit that with the same as men. We escalate the same as men. Bone health, big bone health loss happens within the first 2 to 3 years of menopause, and then after that, it's a slow decline thereafter. And other things, there's not a heck of a lot of data that proves it. So things like osteoarthritis, things like cognitive impairment, dementia, there's anecdotal discussion of it. There's not a lot of data that supports it. However, quality of life, big thing, quality of life with hormones. So let's picture, here we are in the nice 1990s, and what do we do with all these women? Everybody got hormones in the 1990s. You were menopausal, here's your hormone. Why? Because we think that we're preventing heart disease, we think that we're preventing bone loss. And so lo and behold, late 1998-ish is Women's Health Initiative. I don't anybody in healthcare. This is a huge landmark study that in the late 1990s, this was a longitudinal study that looked at postmenopausal women and looked at hormone replacement therapy. What were the outcomes? So it looked at combined hormone replacement therapy, estrogen and progesterone, and just estrogen alone for those women with a hysterectomy. And they were looking at outcomes. Well, the case was it was stopped early because of reported increased risk of heart disease, blood clots, breast cancer. Those are the big findings. So what happened at that point is everybody freaked out and all the hormones went away. So pretty much every woman that was happy with their hormones got it ripped away from them, and they were absolutely miserable. Um, so over the course of the next X number of years, and anybody who is in that age group that lived through this, we providers, this is fairly early in my practice, so it's pretty much like, what do we do with this? Because it's like, oh my gosh, we're killing women if we give them hormones. So at the time, we're like, let's do further digging into this. And when they looked in these data a little bit further and did subset analysis, what they found, bottom line, is that the women who had the higher risk of outcomes such as heart disease, breast cancer, blood clots, were over 60. So the women who are between that 40 and 59, and the women who are less than 10 years from menopause did not see increased risk of these different events happening. So when you see, okay, select who are the proper women to be treated with hormone replacement therapy, um, and you select the right age group, then the risks are not increased. The hard nose from my standpoint in terms of who shouldn't get hormone replacement therapy. Number one, if you have a personal history of breast cancer, generally no. If you have a personal history of blood clots, generally no, although there might be ways around that. And if you have a strong family history of breast cancer or blood clotting, it's kind of a consideration, but not a hard no, just more of a thinking about it. So so that's kind of like how we think about like who can and cannot get hormones safely. Um, so checking of hormone levels, who needs it? Honestly, so many women come to me throughout their 30s and they're like, Dr. Day, I'm having hot flashes. I must be check my hormones, please. And I'm like, the first thing I ask them is, are you having regular cycles? Because if you're having regular cycles, you're not going through menopause and you're too young. If you stop having cycles or you've had a hysterectomy, that's a reason to. The people that we check hormone levels in are primarily going to be women who've had hysterectomies that maybe we're suspicious and we want to make sure it's nothing else, or women who want to do compounded hormones. We're going to talk about that in a second. But let's say a woman is in their 50s, they've stopped having periods, they're having hot flashes, night sweats, vaginal dryness, and they want to say, am I in menopause? I'm like, yes, you are in menopause. I don't need to check a hormone to know that, because that's clinically what we see. So that's kind of the hormone levels. Now, with regard to different types of hormones that are out there, so a lot of it depends on if do you have a uterus, uh, and what type of hormones are you looking for? What symptoms are you looking to treat? When women have more of the systemic hormone symptoms, which night flashes and hot flashes, then I'm going to do systemic treatment. Now, what does systemic treatment mean? My favorite way of replacing hormones for women who have an intact uterus is going to be estrogen patches, because they bypass the liver and clotting risk is less, and a natural progesterone at bedtime, which helps with sleep. And that if you're right after menopause, you've just stopped having cycles, then I'm typically going to do that more in a cyclic way, meaning that every 2 to 3 months, so that you don't spot all the time. Because and if you're maybe a year or so out or more from menopause, I'm going to do it continuously. Now, if you have had a hysterectomy, you don't have to do the progestin. Now, some people choose to, The progestin protects the uterine lining. So that's why women who have had a uterus need to do both. So that's just the rule of thumb. Um, yeah, so it helps with insomnia. So you can do it. It's not, not contraindicated. However, most women who've had a hysterectomy, estrogen by itself is enough to treat the symptoms, and it treats all of it. It treats, and it works within, honestly, a few days. Um, the hot flashes, the vaginal dryness, the vaginal dryness is a little bit later, but the night sweats, things like that, it helps very quickly, and it helps the brain fog and all that kind of concentration issues, and just feeling general sense of good health. It helps like that. Compounded hormone. So a lot of women would like to do more natural type of hormone replacement therapy. Um, and that's okay. The nice thing about compounded hormones is that you can put it all together into one, a troche, and usually it's a troche, which is a little kind of under the tongue formulation that dissolves under your tongue. You do it once or twice a day, depending. But you can put the estrogen, progesterone, and then even testosterone in there, DHEA, which is an adrenal hormone. There are lots of different formulations. So you can adjust it really easily, and that's why a lot of women like to go that way. Um, and the one thing, caveat with that is that with regard to the risks of hormone replacement therapy, there's no data that the natural compounded hormones are any safer. You still have to think about the breast cancer risk. You still have to think about the clotting risk, and at least have that conversation. But very much it's a personal choice and insurance coverage, of course. Now, a lot of women just really have the vaginal symptoms. They really don't have the hot flashes. The vaginal dryness is the main symptom, and the painful sex. So we can focus just on topical estrogen. There's topical estrogen creams, which are messy, but they're cheaper. There are suppositories, Vagifem or estradiol suppositories, which are not as messy, that you can insert vaginally, that you can do 3 times a week. And it really helps with lubrication. It really helps with sensitivity, and the dryness. There are other compounded ways to do it. You can do topical estrogen and testosterone to the external genitalia, and that helps with lubrication, sensitivity, orgasm. There's actually this wacky compounded thing called Scream Cream, which I don't know if anybody's heard about this. It's fascinating. It's a topical vasodilator that goes directly to the clitoris and helps with orgasm. So there's all kinds of funky ways that you can do hormones based on what your needs are and what your wants are. So, I guess from my standpoint, bottom line with this is that, number one, we don't need to be fearful of hormones. Hormones can be absolutely used to improve quality of life in women. How long to be taken? It just really depends on the woman. Most women, it's a 5-year window, is how long they have maximal symptoms of menopause. They tend to go away with time. So we try to wean it with time, so you're not on hormones for 20 years. But you don't need to suffer. There are ways around it, and there are lots of different ways around it. And the other thing that's probably important is that if you're a woman who has chronic recurring urinary tract infections, that is a menopausal thing as well. And topical estrogen creams can help, help the urethra be more supple and reduce that likelihood as well. So that's another reason to consider topical estrogen, pelvic floor strength, all that kind of stuff. So HRT, always willing to have that conversation. And, in terms of the types of providers that prescribe, it just depends. Primary care can do it. They may not want to. So it really depends on the provider. I know that there's a number of, kind of hormone naturopaths out there who do the compounded stuff. They even do pellet therapy. You can even, have an under the skin, a kind of injectable pellet of estrogen, testosterone. So there are lots of different providers that can do this. But like I said, I think I prescribe it almost every day. I'm prescribing hormone replacement. A lot of women come to me for menopausal symptoms, and it doesn't help everybody, and not everybody needs it. That's the other thing. Some people, like for me, I don't take HRT because I don't feel like I need it. But I absolutely am not judging anybody who would like to go that path, because some women literally hot flash every 30 minutes. I mean, they're miserable, and you're just kind of a hot mess, and they don't even recognize themselves. One other caveat is that I know with the weight gain, it's not as straightforward that hormones help weight gain. I would love to say hormone replacement therapy is going to make you lose 10 pounds. It does not. The metabolism just changes as we age. And so, what we have to do at our ages is we have to look at food differently. We have to have a different relationship with food. We can't get away with things the way that we used to. So, it's more incentive to kind of really do the cleaner eating, staying away from the sugar, and all the, high fructose corn syrup and all the stuff that we know we shouldn't be doing, but we do. So, just thoughts for that. But I kind of babbled a lot. So I think I covered the biggest bases. I'd love to have any kind of, so HRT, not something you would stay on for the rest of your life, more than, okay. So here's the way I look at HRT. The way I do that is that, let's say, we decide as a team that someone says, I want to do HRT. The first thing is, okay, decide on the type, and then get you started, and then see what the therapeutic benefit is. How do you feel? Is the dose right? Do we need to tweak things? Are you good? And then what I typically tell women is that, and again, this is going to be a presumption that we're starting under the age of 60. Okay. I don't usually start over the age of 60, but I'm going to say, I always do a reassessment every year, but I don't usually take people off of HRT. I don't take anyone off of it without a big discussion. But what I typically do is say 5 years is typically the window, and I'm not in any rush to take you off of it until around that 5-year window. And then I'm usually having that conversation. It's like, hey, what do you think? Do you think we can reduce? Do you think we can change things? And that's going to be an ongoing conversation. I do have women who choose to stay on their HRT through their 60s even, but that's a personal choice. And so is it recommended that way? Not necessarily, but certainly, if women can make their own choices. So all right. And I know someone sent me another, I don't know how to look at questions. So yeah, I saw it, but I can't read that fast. So is there a place for me to find it?
Do you want me to read it?
Sure. Or you can, I don't even know. Oh, it's on the chat. Hold
Yeah,
on.
it's
Oh,
in the
hey,
chat.
look at this. Look at this. Look at this fancy stuff. Okay. This is not my thing. So, okay. Hi, Kim. 45 hysterectomy in August, kept ovaries. Everything else is gone. Bilateral pulmonary embolism for the, alpha blood thinners. I do a breast cancer history, both sides of the family. What would you recommend for me to test to see how to counteract the weight gain, waking up at 4 a.m.? Okay. So you are absolutely, it's okay. So the bottom line for Kim's question is that she's a high risk of the type of things that I would not want to prescribe. Strong breast cancer history and family, and a pulmonary embolus. So pulmonary embolus, any type of blood clot, is really a direct contraindication as far as I'm concerned. I wouldn't want to do it. So what else can you do? Good question. There are non-hormonal ways to treat hot flashes. They're not as good. I'll just tell you that they're not as good, but they do have FDA approval for this. The things that we use for this, SSR, so serotonin reuptake inhibitors, SNRI, serotonin, and norepinephrine reuptake inhibitors. Venlafaxine is probably the most common. This is an older medication. We use it for depression, but we also use it for hot flashes. And these are classic medications that we use in people who've had breast cancer and really can't do hormones. So helps somewhat. Now, there is a new medication called Veozah, who's been FDA approved for hot flashes, and it works at the neurologic level. I have not used it. So it's available. It's probably going to be expensive. But okay. So let's say, okay. So the most common one is, let's say, venlafaxine, which is generic Effexor. And I wish I could can I just type it, you guys? Okay. Venlafaxine, Veozah is the new medication. And then SSRIs, most of you guys know these, the Prozac, etc. They can be used. There's another medication called, this is a really old medication called Belargal. I have to see, I can't even spell. Belargal. That's an old medication that we have also used, that's non-hormonal, that can be used for, I probably spelled Belargal wrong, but venlafaxine is probably the most common one. Veozah is a new medication that I don't have any clinical experience with, because usually these things are cost prohibitive, but it is FDA approved for hot flash treatment. And these are all for hot flashes. And then the other thing I do for a lot of women is, let's say that their primary menopausal symptom is mood disorder, and insomnia, and they don't really have the other symptoms. Then I might specifically say, hey, let's target the mood issue. By the way, I'm a huge fan of counseling. Uh, Cognitive therapy really does a great job in really helping us understand where we are in our lives. So I'm always a fan of counseling, but I'm more likely to discuss, depression medications such as Prozac, Zoloft. You guys all know the class for mood disorder, with something to help with sleep if necessary, if hormones are not something you want to go. So, hormones are something that if you're going to do it for mood only, that's a little bit harder to know. I mean, there's not as much information and benefit with that. And there are risks. So hormones do have some risks attached to them. So you just have to be aware of that. Okay, so Kim, are you waking up due to hot flashes or something else? Dr. Day does perimenopause because I wake up at certain times through the night. Indeed, yes. What are your thoughts, Kim? Okay, so it's not hot flashes that you're waking up for? Or night sweats? Yeah. Um, so you had your hysterectomy in August of 23. Okay, so kept your ovaries. So do you have hormone levels? Do you know if you're in menopause? Yes. So that's an example of, here's the thing, is that if you have had a hysterectomy with intact ovaries and you are under the age of 50, then there's a good chance you're not menopausal. So if it's not a hot flash thing and you're having issues with insomnia, gosh, there's so many different reasons people can have insomnia. It sounds like you've perhaps had your hands full of stuff that have gone on in your life, medically, maybe other stressors. Insomnia is probably the most common things that honestly I deal with. And so many of us have issues with insomnia, myself included. And it's usually not a straightforward answer. But hormones are easy to test in that situation. If you had a hysterectomy and you have intact ovaries, you really won't know unless you're tested. And if you are menopausal, um, again, but even so, the thing that you have to keep in mind, Kim, is that because you're not really treating hot flashes, you're treating pure insomnia, then perhaps the way to address that is to treat insomnia. And there are non-habit forming medications that can be used. Cognitive behavioral therapy is a great thing for insomnia. Biofeedback techniques, relaxation techniques, melatonin is a lovely medication. There's other over-the-counter valerian root, relaxium. These are kind of more herbal things that have kind of some of the neurochemicals that go along with mood that are available over the counter to try to interrupt that sleep wake cycle. Once you get into that insomnia where you wake up in the middle of the night, what probably most of us do wrong is that we wake up and then we start saying, oh, I'm awake, so therefore I'm going to start reading my iPad, or I'm going to go get up and walk, and we make ourselves more awake. So just be aware of that. There's a lot of different parts that go into insomnia, and it's probably worth a discussion with your doc. My long-winded way. Okay, next, 49 years old. Real symptoms, waking up at 4 a.m. Yeah, me too. Not sure if it's menopause or high cortisol. Haven't had hormones taken. 49. I have MTHR. Yes, and the MTHFR is not a direct contraindication, just so you're aware of that, because that's an arterial blood clot issue. And if you, MTHFR, I won't get into the details of that because that's probably not really related to this talk, but MTHR has to do with arterial blood clots and its increased risk for coronary disease, but it doesn't mean you can't ever. But family history of breast cancer, yeah, fair enough. Okay, so the insomnia question. Yeah, I mean, like I said, I don't, if insomnia is your primary symptom without the night sweats, then I would target the insomnia. And again, so much of insomnia relates to sleep hygiene. And sleep hygiene, what that means is, how well do we take care of ourselves? What's our bedtime routine? How do we calm ourselves down? And how do we set ourselves up for success? And like I said, meditation, biofeedback, um when you wake up in the middle of the night, don't freak out, but rather, and my husband's a huge fan of those sleep masks that have Bluetooth with meditation apps in them. He loves his. So those are a worthwhile endeavor, so that you can try and not go the pharmaceutical route if you don't want to. It's always best to try other techniques before going pharmaceutical route. But like I said, I'm a believer. Melatonin, I think, is pretty harmless. uh Sound baths on bot. Oh, hey, I like that. That's lovely. Yeah, that sounds like a lovely idea. Yeah, there's all kinds of different. It's interesting because we all bring like what relaxes us. I mean, for me, I grew up in Pennsylvania, so for me, hearing the rain on the windowsill, that's relaxing because that's my world. Some people it's like waves. Some people it's like wind. So there's all kinds of different sound systems and relaxation apps that are out there, and sounds like Body has them. New autoimmune diseases. Okay, hold on. Do do do. Autoimmune diseases with menopause. Um, hmm. Uh, I mean, I'm not aware of specific autoimmune diseases that are attached to menopause. Autoimmune diseases are pretty common. Most common in women is Hashimoto's, and autoimmune thyroid disease. There's a lot of autoimmune diseases. Um, I don't have direct information about relation to hormones versus not with them, but certainly I see a lot of them. So I don't know if I can be more direct in answering that question. Can you explain the main hormones you test? Yay. Okay. Sorry, Christine. I'm babbling too much. Okay. So, okay, the typical hormones that we're going to check when it comes to menopause are going to be estrogen, estradiol level, progesterone level, testosterone level, and then the pituitary hormones, FSH and LH. So, follicle stimulating hormone and luteinizing hormone are the pituitary hormones. And here's the what happens with this is that there's a feedback loop with these hormones. So as your hormone levels start falling, then your body says, I need more of the hormones. You're not making enough hormone, make more hormone. So what happens? Those hormones in the pituitary go up. So typically, FSH levels greater than 20 or so are diagnostic of normal. Like let's say you're a cycling woman, you're typically going to be under 10 for both of them. But if you're heading over 10, then you're in the process. Now I know that there's a lot of the naturopaths do other levels of DHEA levels, estriol levels, things like that. Um, and there's not really a lot of literature to back those up. So, for me, I keep it relatively simple. And one thing to keep in mind is that early in the menopause, one of the first hormone that drops is your progesterone. And so for a lot of women, they get breast tenderness, insomnia, some night sweats, and it might be as simple as a progesterone cream that might really help those symptoms and bridge you until you are in the menopause, because there's an imbalance of estrogen and progesterone that happens early in the menopause with that. Okay, I hope that answers the questions. And if the results are irregular, okay. So here's the other thing about hormone levels is that if you're checking hormone levels when you're cycling, then they're going to vary. And there's different phases of your menstrual cycle that when you're checking hormone levels, there are going to be certain levels based on where you are in your cycle, and without going into more detail about that. So it's important to know where you are in your cycle. But really, honestly, probably the most sensitive marker of menopause is going to be those pituitary hormones, the FSH and the LH. And if they're low, then you're not menopausal. Now, could you repeat them if they're borderline in another month? Of course you can. But honestly, so much of this is we're going clinically. If you've had a hysterectomy, and like I said, you don't have menstrual cycle and you're having classic symptoms, the hormone levels should be representative of where you are, so they should not cycle as much. But okay, hope that answered that question. Okay, 59 and a half, turning 60 in November, hot flashes and was waking up in the middle of the night. Started estradiol, 3 weeks ago. Has helped very much. Yep. I came in at the remark of 5 years. Yeah, Intertech 9 years ago. Yeah, so here's the thing about, you just have to be a little bit more cautious when you're 60 and doing this, just because of the cardiovascular risk increase. So that's where you have to start being aware of that. So the rule of thumb is that you should be under the age of 60 and you should be within 10 years of your menopause. So you sound like you're right on the edge of that. How long to treat? I typically try to keep it at 5 years or under, because when you look at the breast cancer risk, no increased risk in 5 years. After 5 years goes to about 7 in 10,000. So the risks increase the longer you're on it. Um, and so that's something to consider. So what I typically would do, and there are people who use estradiol. You're on the patch. Yay, I love the patch. So yeah, I mean, I think that if you symptomatically are feeling better with it, then absolutely, just be aware, and always want to use the lowest dose that works for your symptoms. So that's one thing for you to consider, is that great, you started the 0.05 milligram patch, but let's say maybe after you've been on it for a year, maybe you go down to the 0.0375, the 0.025. The lowest dose that works is what you want to try and target. I hope that answers your question. Anybody else? I hope I'm helpful. Hope I'm making sense. It's good stuff
Welcome,
though. Good questions,
welcome,
everybody.
Robin. Robin, you're on now. I'm not sure her family is in like a little trailer and they're going all over the United States and homeschooling. Robin, sure where you're
Very
at
cool.
now. Any questions? You just jumped off lately,
Yeah.
and she's worked really quite a bit of weight lately. I don't know if she can hear me. I am.
Yeah, you're kind of breaking up. So she lost quite a bit of weight. Is that what you're saying?
Yeah, she's working really hard and she's been on
Hi,
the go,
sorry.
like in a,
I forgot I could talk.
are you there?
Yes, can you all hear me?
Yes, I can hear you. I can hear you.
Yeah, okay. So yeah, I've lost 40 pounds, but that's so now I'm like at 188. But right now I'm doing great. And we don't have full access to our doctors with our traveling,
Mhm.
which kind of sucks. So I can't get my hormones checked, but things are okay. I mean, I just wake up sometimes, which is weird for me, but other than that, I'm not having any issues. I have a 12-year-old that's super hormonal, and I think that I'm still having my period even though I have an IUD.
Well, you're still ovulating. I mean, IUDs don't keep ovulation from happening. So
Right.
you
So
absolutely could be
yeah.
our sympathetic thing. So yeah, so congratulations on your weight loss. That's fantastic. I love to hear that. So do you mind me asking how old you are?
Oh, I'm 49.
49. Okay.
So I
So you
know
have an
this is
IUD.
coming,
Uh-huh.
I guess. So
Yeah, I mean, I guess this is the thing, is that the IUD, which kind of IUD do you have?
the Mirena, and
Oh, I know. I
Mirena.
love it. I'm on my third. I have to have it pulled, but I'm a huge fan of
Well,
Marina.
every time I go in to get it pulled, I had an ovary removed in November
Uh-huh.
because I had a cyst the size of a friggin' uh, it was a size of a mango. So
Oh, yuck.
I was
Ouch.
able to get back to Colorado, and my doctors were really cool and were able to
Nice.
see me right away and get this thing
Nice.
removed. But I'm
Yes.
down one ovary and I'm not having any complications yet. So
Fantastic. Yeah,
yeah.
the thing to remember about IUDs is they don't actually interfere with your hormonal cycling. All they do is what a Mirena is it's topical progesterone, and so it just thins out the lining of the uterus. So and IUDs you can't implant. That's kind of how IUDs work. But the nice thing about Mirena or Kylena, which is the 3-year version of it, is that it thins your uterine lining. So most women, your periods go away. I haven't had a period in 20 years. I love the thing. Obviously, I'm done now, but it won't affect your actual hormone fluctuation, and in terms of ovarian cysts and things like that. But I wish it did that, but it doesn't. But it sounds like you're not really there yet. Sounds like you're still kind of hanging in there at 49.
Yeah,
The
it's hard to
oldest I've ever seen
tell.
is 58. I have a lot of women who still are not going through the change yet, and until their mid-50s or late. But good for you. And the thing is that what happens a lot of times when women who have had considerable weight loss is their hormones kind of get confused. You think about what a body wants to do. It wants to preserve its weight, and your body never wants to lose weight. It wants to preserve energy. So frequently with women who lose considerable weight, either they're trying to or they've been sick, is their periods get all wonky because their hormones are confused. And that's a very common thing. It typically will re-regulate itself out once you stabilize. So it's possible to feel a little bit kind of wonky with the weight loss, but it usually regulates its way out.
Awesome. Yeah, I just sometimes with the Marina, you can't tell if you're still
You
having
can't.
a period. So every once in a while I get some spotting and it's usually on
Yeah.
a timely basis. So I figured
Okay. Some women do. Some women will still have periods. Yeah. So, but it's usually pretty light. It's usually much more
Yeah.
manageable for women. It may or may not be cyclic. But either way, it's usually good for thing for most women. But congratulations. That's awesome. I love to hear that kind of story.
Thank you.
Heather, you had asked real quick. I'm sorry. Do symptoms last forever? The average length of time for menopausal symptoms of the hot flashes, vaginal dryness, all that is 5 years. That's average. So some women, like I said, my mother was still hot flashing in her 80s. So it just depends on the person. But it tends to get milder. The worst of it is usually right, like within 1 to 2 years after you stop your cycle, or you're in the menopause, so to speak. That's when it's usually at its worst. So it usually gets better with time, but some people it doesn't. And that's why the discussion's out there. Rage in rural Minnesota is bioidentical hormone. Yes. And the peptides in your right. Oh yeah, the implant. Yes. Yeah, here's the thing. This is when I'd say I should have called it bioidentical, because that's what it is. The compounded HRT is bioidentical hormones. And the whole rage of it is that it's more natural, therefore it's safer. So just I'll keep reiterating that there's no data that it's any safer than any other. It's okay. A lot of women love the pellets, and the pellets can be just estrogen. They can be estrogen and testosterone is usually used for the libido issues. Um, the you know, so testosterone is like if you have low libido, or difficulty with orgasm, things like that. That's what testosterone does for you. So yeah, I mean, a lot of women love it, and sure, it's trendy. But and like I said, there are providers who, what I like about compounded is that you can alter the doses. Let's say that you come to me and you're like, gosh, Dr. Day, my breasts are super tender, and you're on 5 milligrams of Biest. And I'm like, well, let's look at your levels. Okay, we probably want to reduce the estrogen part of this and leave the others alone. And you can alter that. That's the great thing about the bioidenticals. So that's kind of how I would use them. But it's also a personal preference, because I know a lot of women really feel strongly that they want to go the more natural route, and that's all great. There's no problem with that. So does that make sense? I hope that answered your questions. I love them. I think they're great. But insurances don't love to pay for them, so they might be a little bit more costly. Okay. Yeah. So, the thing about history of blood clot, history of any kind of venous thrombosis, as far as I'm concerned, anything that the highest risk estrogens in that situation, and it's estrogen primarily that causes blood clotting, is going to be anything that you take by mouth that you swallow and it goes through the liver metabolism. So estradiol tablet, Premarin tablet, those are your higher risks. Now, when you're doing pellet, when you're doing under the tongue troche, when you're doing patches, the risks are less, but they're not zero. So I really don't recommend estrogen-based HRT for anyone who really has had a blood clot, because it absolutely can increase your risk. So that's just something that, yes. So you'd have to be really hard pressed to really want to do hormones in that situation, because it is a higher risk. Is it normal to get breast pain as we age? Yes. And breast pain, yeah. So here's the thing about breast pain. Breast pain is the most common in the very early menopause or perimenopause, because what's happening in that point is your progesterone level reduces first, and then the estrogen level catches up. So when you have that imbalance of progesterone being here and estrogen, reverse that, estrogen being here and progesterone being here, breast pain is a very common symptom. So breast pain can also be a sign of too much estrogen. If you're on hormone replacement therapy and you say, gosh, Dr. Day, my boobs hurt, I'm going to be looking at reducing your estrogen dose, because that's typically what causes that. Again, I'll reiterate that if you're perimenopausal and maybe you haven't gone through the change yet, but you're having breast tenderness, a topical progesterone cream is very helpful for that. You can get them over the counter. You can find them online. They're just low dose. You can get prescription compounded version of that through either a compounding provider or a primary care physician who's used to that kind of stuff. But that's something that you could do to treat that symptom.
And Debbie DeGarry, I know you're here. Show what you're making. She's a tutuologist. Is that such a word? She makes tutus, and she's amazingly.
Oh no, really?
And yeah, Debbie, I know you've had a couple things going on lately. Is there anything you want to share, or some questions you have for Dr. Day? Her thing's frozen, so I'm not sure.
Can I
Oh, there
ask a
she is.
question in the meantime?
Sure.
Yeah.
This is Olga. I'm sorry, I'm at work and my phone is not allowing me to do video and chat.
Okay.
So I am 59 years old. I went cold turkey, nothing. I'm already postmenopause, almost about 5 years, I think. I lost track.
Mhm.
So I went cold turkey. I didn't have any hormone treatment or anything. I mean, I do have trouble with sleeping sometimes. I did gain like 10 pounds, which I struggle with, belly fat mostly. And I don't know, do you have any advice, or, what should I do?
Yeah, I guess here's what I would say is that, and I kind of touched on this earlier, that when it comes to what we all go through in menopause, I have yet to meet a woman who has not gained weight in menopause. Everybody does, and the problem is that hormone replacement therapy does not make it go away. So don't be thinking that hormones are going to make your belly fat kind of go away. This is the challenge, is that when we're these ages, our body reconstruct, our body shape changes. Nobody gets away without this. I mean, unless somebody's going to get all kinds of surgery and they're Hollywood people. But all us normal women have weight gain that happens around our middle. That's our clothes are tighter there. We don't fit as well. And I would love to tell you that there's easy ways to get around that. You know, my personal experience is I pretty much did the same thing as every other woman, gained my 10 pounds probably earlier this year. But I admit I was being a little bit lazy. I admit that I was not at clean eating as the way I should be. And, I'm like, oh, for goodness sake, this is really stupid. So, I made a decision that I was going to pretty much cut sugar out of my diet. And the thing about sugar in the diet is the less you have of it, the less you want of it. And I know all you nutrition people know that. You don't crave when you are able to get it. Now it's hard to get it out. I will tell you that. But and then I was able to lose 10 pounds. So, and I'm not saying that because of me. I'm saying that because this requires work, and there is no way to get around not doing the work. You will always probably have a little bit of the tummy. And of course, it's personal choice if you want to do any of the interventions that women do, cold sculpting, whatever. I'm not a big fan of that. I'm a big fan. What I feel like is most important, because I think that we women are very body image based, and we're very hard on ourselves. And so we have this image of like, oh, I need to look like this, and I don't like my shape, I'm unhappy with myself, self-identity issues and things like that. I really would have people really focus on health. What does that mean? That means being active, being able to do what you want to do, being able to use your body, being able to feel great energy, and the shape of the body becomes a little bit less. I mean, I still got my belly, and I know that that's just, it is what it is. But I don't know. I would say that when we look in the mirror, we're our hardest critic, and I can guarantee the people around you are going to look at you and say, "Gosh darn it, you're beautiful." Your partner, whoever that is, you know what, you're beautiful. I love you. Those are the kind of things that we have to figure out our own self-worth in these ages, and not be so hard on ourselves, and understand our bodies are going to change. Pregnant women, our bodies are never the same after we had kids, right, ladies? Anybody's had kids? The body is just not the same. You can't get the same thing back. But you know what? That's okay. Those are badges of honor. And menopause is another badge of honor. We've lived this long. Look at us. We've got another 20 years to go. So we've got plans.
One last
Anyway, I hope
question.
that's helpful.
Yes, thank you so
Yes.
much. How about being tired? I feel like I'm
Tired.
tired all the time.
Yeah. So here's what I do with that. I will say far and away, and I don't know, where do you live, ma'am?
I live in California.
California. So I always look for other reasons for tiredness. Hormones are not as clear-cut tiredness. They can be, but it's usually attached to insomnia. I have a low threshold for screening for sleep apnea in pretty much everybody because I see it so commonly here in Colorado. And a lot of time when people come to me and say, Dr. Day, I'm just so tired. I wake up, I'm unrefreshed. My sleep is interrupted. I never feel like I get good rest. I screen for sleep apnea. I do a home sleep study. And I would say about at least 80% of the time, yep, there's some sleep apnea in there. Now, that being said, other things, I look for anemia. I look for B12 levels. I screen for depression. Kind of get a better sense as to kind of what is the tiredness, what type of tiredness. Are we talking sleepy tired? Are we talking like short of breath and I need to be looking for heart disease tired? Tired is one of the most common symptoms that I see. And so I'm going to go through a litany of what else could it be before saying, oh, honey, it's your hormones. But hormone replacement, I would be hard pressed to recommend that for you. I would have to really rule out everything else. So it's definitely worth a discussion with your primary care provider and making sure that nothing's being missed before going the hormone route. I mean, I think a lot of times what happens in our ages is that, the hormones become a wastebasket. Everything must be your hormones. And it's like, well, it's your hormones. My mother was told it was her hormones for I don't know how many years, and turns out she had an insulin producing tumor of her pancreas that was making her hypoglycemic. Oops, big miss. So that's what I mean. Don't assume it's hormones. Get yourself evaluated for other possibilities. There's about a bunch of them. And then if you're left with hormones, then you can have that discussion.
Okay, great. Thank you.
How often do you recommend screening for vitamins like the B12, magnesium, vitamin D, and cortisol? Yeah, so I guess here's the thing. How often? Well, most certainly once. When people come to me and they say, oh, I have chronic fatigue, then those are tests that we're going to do. Now, cortisol is an interesting one because, what we Western medicine people do is looking for adrenal insufficiency. So it's a different beast than this adrenal fatigue that a lot of the naturopaths are looking for. So the way that we test for it is completely different. So, but more than often, there's a cheek swab for adrenal fatigue that the naturopaths do. And a lot of times they'll put women on a natural kind of adrenal supplement. That's kind of what they do. I don't do that. I'm looking for adrenal insufficiency. And so you can do a screening morning cortisol. And if it's over the normal, I think it's over 7, then it's unlikely to be that. But again, true adrenal insufficiency is pretty uncommon. So, but the adrenal fatigue thing, yeah, that's something that more the naturopaths do. But B12, vitamin D, magnesium, sure. Vitamin D deficiency. Everybody in Colorado is vitamin D deficient. I recommend pretty much everybody. I personally take 5,000 units a day, and I'm a big believer in vitamin D and general health and prevention of viral illness, maybe cancer production. You can get too much. That's something where you need to be monitored. But I love vitamin D. B12, sure, if you're deficient. A lot of women feel better with some vitamin B12, so it generally isn't going to harm you. But you can certainly, do. But to check it every year, probably not necessary. Once you know what your level is, you probably don't need to check it all the time.
Great. Well, I know we're getting right to about an hour right now. So Debbie DeGarry, I want to open that up to you because I know you had a question, and then we're going to wrap things up because we appreciate everybody's time. Let's see, where did Debbie go?
I have to push a button to talk, I think. Can you hear me?
Okay.
I can hear you.
So I pretty much have like every nasty menopause symptom on the books. But hot flashes are the least of my worries. And I've been gaslit by my doctors trying to give me hot flash antidepressants, and my main thing is joint pain.
Mhm.
And I've put 40 pounds on in the last 5 years with no change in diet. I walk 2.5 miles a day with a weighted vest.
Mhm.
I've started intermittent fasting, and that is the first time I've actually been able to drop any kind of weight.
Okay.
But I'm literally not eating. I mean, I have a 5-hour eating window, and you just can't fit much in there. So my energy levels are super low, which I thought was from the fasting, but turns out I got thyroid issues too.
Okay.
And my cholesterol has spiked since menopause.
Can be.
Which-
I mean,
Oh, and the gums,
And-
the receding gums and the moving teeth. That's another one nobody talks about.
yeah, I mean, I guess here's the thing is that you kind of the things that you're describing, that yes, absolutely, these are things that absolutely can be menopausal for some women, and probably the most important thing, from my standpoint, is that every single woman is individual and it's all different for each one. And when it comes to metabolism, some women are just really cursed with a slow as molasses metabolism, and how to work within that, it's complicated. And I would love to tell you I have an easy answer. And there's all kinds of different ways that we can intervene. But I hear your frustration, and that's probably an important thing. Is it's frustrating, but there are different things that can be done to help you. Like I said, I think the most important thing from my standpoint is that you got to have a provider relationship where you guys are mutually trusting each other and you're listening to each other. So, and then if you don't have that, then that's something where you might want to kind of look around and
You don't really have a choice when you have military health care. You get who you're assigned to.
Yes, I mean, Colorado is a military world, so I have a number of folks that are military and even active duty people.
Well, I have to
So
be seen on the base, so
fair enough,
okay.
fair enough.
So that's
So then you're stuck with, okay, well, I have to be seen on the base. My doctor's not listening to me. What should I do? You might want to visit with a naturopath then, if you haven't, because here's the thing, you're going to have to think out of the box. Right. So what you're doing is not working. I can hear your frustration. What's the easy answer? Well, if there was one, you would have figured it out by now. You strike me as an intelligent person.
Oh,
So
I've tried everything on the internet that pops up on Instagram, and I can tell you, ladies, it doesn't work.
Okay, so here's my thought with this world, and again, I don't have all your medical history. However, with my people who have struggled with weight like this, and I don't know what your BMI is, but if your BMI is over 30 and you're literally like, I'm not eating and I'm not losing weight, you're the person I'm going to talk about these GLP-1 inhibitors like Ozempic, like Wegovy. Now, I know everyone's got their own opinion about that, but I just want to put this out there because I have a lot of personal experience with this one. I have a patient who is 65 and she's got all kinds of weight consequences, and she weighs probably 300 pounds. And she literally says, I eat nothing. I eat 800 calories a day and I'm not losing weight. And I believe her. I mean, I think there's some people who are that struggle with this. However, she's one that I would prescribe this for, and you can get these compounded. So that's just something to discuss with your people. But my point with this is that I finally was able to get her on one of these medications, and in 1 month she lost 12 pounds. Now, what happens with that? So what happens with these meds is that cravings go away. Food becomes less interesting. You don't think about food all the time. And so that's the fascinating part. And for people who have that rock solid, slow metabolism, okay, then they still work for them. They still work. So something for you to think about, and perhaps something that you might want to consider, getting yourself a provider that's out of the military. Military's not going to do this. They don't care. They just give you ibuprofen and you're on your way. So what you need is to say, okay, get yourself a good naturopath that you can say, hey, listen, this is me, help me. And they will. So there's different ways to go about that. My point in telling you that is that don't accept what you got as what it has to be. There are other ways. You just have to think it's like, well, what works for you, because you're an individual. And so what you need is different than what this person over here needs. So, that's what, that'll be my recommendation for that.
Yeah, I
Dr.
feel like all the things are like, it's like a self-licking ice cream cone. If you have more weight on you, your joints hurt more. If your joints hurt more, you're not
Indeed.
walking and you're not losing weight, and you're just
Yeah.
like spiraling out of
So
control.
I'm going to say that 2 things I would be doing for you is, number 1, I'm going to screen you for sleep apnea. I beat this dead horse because I see it all the time, and it contributes to why people keep weight, because their cortisol levels are always high. So if you haven't been tested, consider one of these medications. And I love, Robin, you're mentioning this. Do not be ashamed of being on these GLP-1 inhibitors. They work like magic, but it's not for everybody. Somebody needs to lose 10 pounds. No, forget about it. But for women who have BMIs over 30 and they've struggled their entire lives, yeah, I think they're a great alternative. And what I'm having to do is I prescribe it at a compounding pharmacy, because you can't get it anywhere. The US nobody can get it, but you can get it compounded. And there are different providers through town that do this. I'm sure where you are, there are people who do this. I can get a prescription for it for $100 to $150 to $200 a month, which is dirt cheap compared to what it usually is. So those are something to think about. So for anybody in Colorado Springs, College Pharmacy does this for upwards of $100 to $150 a month, and I can prescribe. So you don't have to see the other homeopathic specialists. But the going rate is $300 to $350 if you're going to go to a naturopath or a chiropractor. A lot of people do it. Don't get it from China. That's my one recommendation. But beyond that, I think there's a lot of different ways that you can potentially get it, and we all have to think out of the box, because no one can get it. But again, not everybody needs it. So keep that in mind. I'm not recommending for everybody, but for someone like you, it works like magic, just like magic. I've had people lose 50 to 100 pounds on these meds, and people have struggled with compulsive overeating their entire lives. So, something to think about.
I guess we should probably wrap it up just because of time. But it's been so helpful, and it sounds like we might need to have Dr. Day back again, because
Hey, I can talk about it. You guys know, you see, I love to talk. So yeah, I'm happy. Christine's one of my favorite people. So if you need me, I'll come back.
That's awesome, because so many good questions, and I think there could be a to be continued even about this last topic, because
it's a big topic. Big topic.
Yeah, it is a big topic, and I think that just understanding when people get off it and the repercussions of that, and not being on a long time. But we don't have time for that tonight. But I raise your hand if you'd like part 2 on that whole topic. Okay, so yes, I think that might be a one for the future. Just to wrap this up, I want to thank Dr. Day for her time today. I want to thank all of you for being here and being very attentive and having great questions.
Yeah, you guys had awesome questions. Thank you. You made me think.
This will definitely help all the people that are watching the video as well. Just some final things to wrap up, because it's the last week already. So make sure you guys all pull out your self-care bingo. Congratulations to so many people that have gotten their bingos throughout this whole time of doing different self-care things for yourself. Be on the lookout for the end. We will be awarding $20 gift cards for a raffle for anybody that's done at least 3 workouts a week for 4 weeks in a row. So you'll be in for that gift card. And if you've had your Shakeologies 4 weeks in a row, 3 times a week, you'll be in that, as well as sharing your success stories. So please share your success. And then finally, remember, yesterday, Kim posted about Tuesday's word of the week for affirmation. So we have, I am worthy, I am consistent, I am motivated, I am helpful, I'm observant, I am confident, I am capable, I am kind to my body when it needs rest, I am confident. Another one, I am confident. So if you haven't filled yours out yet, make sure that you do. We'll be pulling a prize for that as well. And she'll be letting us know tomorrow who the lucky winner of that is. So thank you so much for all of you guys being on today. We will end the video right now, but with just some final, if everybody wants to shout out a nice thank you to Dr. Day, you
Thanks,
can do
everyone.
that.